Да, почему здесь?
В первом зале. 700? Добрый день, уважаемые коллеги.
Good morning, good afternoon, and good evening, dear colleagues. And we proceed with our Congress. Today, we are in Hall 1, more than 1,000 live connections. And this is a very special high-track, high-speed session. And I would like to remind you that this is a very special feature for the Eurasian Association of Therapists Congress. So these are very short, very precise presentation. One question, one answer. So 7-8 minutes to each speaker, and then fantastic discussion, diving deep into all the questions from the audience. After all the presentations, we are going to enjoy in a few minutes. So today, we will have extended time for the discussion, so please stay with us. And I'm calling everyone, 1,000 people who connected us today. No hesitation, please provide your questions. Well, the first question has already come before the start of the session. Fantastic. Please provide your questions. And if this is a question to one specific speaker, so please let us know that this is a question to this or that professor. So we will try to cover all possible questions. We gave extra time for Q&A because it's very important. Because yesterday, our special session was focused on CHF. And actually, we answered more than 20 questions, but they were asked more than 200. But today, our fast speed session is extended. This is CHF plus CKD, because this is very obvious that in 2022, and for the whole story of medicine, we will have to perceive these indications simultaneously, in tandem, in cardio-renal connection. You can call it cardio-renal loop or whatever. We should understand that this is our future, CHF and CKD, CKD and CHF. And without taking too much of your time, we start our high-speed session. So I will start with my presentation. Please show the screens and please show myself. Well, unfortunately, it's a little bit of sad to be the first in a high-speed session, because you know you are just the beginning, and after you there will be something more, something juicier, and you have just 7 minutes and only one question you need to answer. So my task today is to answer a very simple question: new risk groups of heart failure and CKD. New risk groups, that's my topic. So 2020, I will be very fast. Cardiovascular mortality is reducing. Yes, reducing. And we got advantages, oncological mortality over the cardiovascular mortality in big income countries. But the situation is changing. And it's changing together with pandemia, because it gives a terrible hit on the patients, on the health of the patients. Well, now it's very difficult to analyze how many patients have already suffered, because that's more than 1 billion, those who have mild, moderate, or severe, or even asymptomatic. We speak about the classical modern patients, comorbid patients, extra weight, obesity, hypertension, dyslipidemia, etc., etc. In the Russian Federation, we had 61 and 7%. 61 and 7%. These are all residents of the Russian Federation. They are overweight. 61% obesity or overweight. And they are definitely in the group risk, in the group where there was a burst of new cases of chronic kidney disease and new cases of CHF. Well, how it's all happening? Let's try to dive deep. Initially, we know very well that chronic kidney disease is more frequently seen in the overweight patients, and that has been confirmed by the registry of 12,000 patients. That's registry on COVID-19. But if we go deeper, we will see something fantastic, something really interesting. CHF would reduce CKD lifelong, but when patients have acute kidney injury, AKI, then that's a dramatic drop. So the higher is the body weight, the higher is the probability that at the hospital stage, the patient would face acute kidney injury. Underdiagnosis, terrible underdiagnosis. So stage 1, KD is not seen, we miss it. And at the end, we get the burst and the terrible worsening of CKD. The onset, de novo CKD through albuminuria, through GFR less than 60 in all patients. And this is terrible. So the problem is getting bigger. Now the body weight we see, so it leads to excessive inflammation. This is a topic for 10 lectures. I'm not going there, but this is obvious. The higher is the body weight, the more is the inflammation. And all that is confirmed histologically by a number of studies. Now we can see the speaker and now we can see the slides. So you can pin it and make it bigger in your screen to see it better. In the previous sessions, we discussed inflammasomes and other factors. Then we see the progression of heart failure at the end. And moreover, these people who overweight, obesity, they had not simply severe inflammation, they were reinfected. Just think it over. 75% had infection twice, 20% had infection 3 times. And this is very recent survey data. I think this percentage is already higher. And last but not least, CHF de novo. These are the same patients. Well, and now we understand that the register that we carried out completely coincides with the national cohort study of the United States, where 87,000 patients were included. Younger patients, patients who have very different cardiovascular diseases, patients overweight with obesity, absolutely the same patients with CHF de novo, the onset of CHF. So Russian active register is absolutely similar to the US register. Our age is younger, 65 on average, but hypertension, dyslipidemia, younger than 60, CHF de novo, including other diseases. And you see that giant registry, 600,000 patients, United States, those who had COVID in the medical history, you see. So everything that goes to the right, no matter age, race, ethnic group, we see the onset CHF go through inflammation, through loss of kidney function. This is unfortunately unavoidable reality. And this is what we experience now. We truly see it as there is a very strong link between CHF and CKD and number of acute kidney injuries in the whole CHF population. Wrapping up, I would like to say the new groups of patients, they are here, they're around us, they are with CHF and CKD. That's the huge pool of patients, 60 plus, they had COVID, and no matter how severe the COVID was. So all these patients should have the control of GFR, preferably BNP and echocardiography. And then you will be surprised, you will be shocked how many CHF de novo you will find. So answering my question, all those patients who had COVID are in the risk of CHF and CKD at the age of 60 and 60 plus. Now, I finished my presentation. I finished with CHF, and now I'm happy to give the floor to the next speaker, and this is Yuri Mareev. He will speak about CHF and the diagnosis of CHF patients. Is it a threat or is it already a battle? Microphone is yours. Welcome. Good morning, colleagues. I'm happy to proceed. That's my conflict of interest. Speaking about CHF, it's important to make the correct diagnosis. In Russia, we use the criteria of European Society of Cardiologists of 2016, and later on in 2020, they were approved in Russia. So in any case, the diagnosis of CHF requires symptoms and signs. Then, depending on the ejection fraction, we have three types: reduced, preserved, and moderately reduced. So we take these criteria: increase of BNP and particular structural changes of the heart. We have to say that in 2021, ESC offered amendment of the classification. So now low fraction, reduced fraction starts from 40. In a moderately reduced, it's not necessarily additional criteria, and also here the structure of additional criteria changed for HFpEF patients, and for HFpEF I will speak later on. So the key message in the diagnosis of CHF is symptom and sign. It could be different from the classical artapnoea and edemas. Then it could be dyspnoea and shortness of breath, which is also typical. And we have to put the diagnosis very simply. You see increased venous pressure, you see ankle edemas. So we also look at the features around the neck. This is increased jugular venous pressure, auscultation of lungs, rails or wheezing. And also, sometimes the picture is very vague, a little bit of dyspnoea, and it's difficult to differentiate from COPD, from asthma, from post-COVID. Sometimes it's very difficult, and totally opposite. It could be edemas, and then we cannot always differentiate CHF from something else. So we should always be cautious, and we should always be comprehensive. We should take patient holistically. So if you have some doubts, how we can confirm or reject the diagnosis? Well, definitely X-ray. X-ray, well, no congestion, but in case of CHF, we see the pleural effusion, for example, here, and increased silhouette of the heart, and also periheliar congestion. So X-ray could be very helpful to confirm the diagnosis. Also, ECG could be additional method, but it doesn't give us the definitive diagnosis of CHF. And what is very helpful is NT-proBNP and BNP. Please remember, so in case of CHF, both BNP and NT-proBNP should be assessed, because in the normal circulation, we see very low levels, but they increase in CHF. Also, echocardiography, if it's HFrEF, so it's already symptom, and HFrEF, it's already the diagnosis. But in case of HFpEF, then echo could be helpful, and we need additional criteria. And now we face challenges. To put the diagnosis HFpEF is very difficult, because there is no one marker. Because yes, in case of HFrEF, it's symptoms, and that's it. But in HFpEF, elderly patients with lots of comorbidities, not many reasons of shortness of breath, many other reasons, so it creates difficulties for diagnosis. Well, NT-proBNP, they can be increased even without CHF, but on the other hand, it could be low BNP, although there is HFpEF. Echo, not easy to interpret. Now let's look at the example. So 3 ways of making diagnosis of HFpEF. So 3 examples. And here you see, this is American College of Cardiology 2013, where you can have normal ejection fraction, and you should be sure that symptoms are not related to something else. This is ACC, AHA. Then ESC, that's what we discussed, this Ponikovsky publication in 2016 article. So this is LVH, LAE, ODD, and not dilated. And also HFSA criteria. So here we need symptoms and signs, both. So, and there was a study carried out and published in Circulation in 2019. So patients were taken according to ACC 2013. So they made a diagnosis for 461. Only 25 met ESC criteria, and only 55 met the criteria of HFSA. Well, such a discrepancy. You see, different criteria, different number of patients. Oh my God. So, can we reproduce this data? Yes, we can. because there are multiple publications. Please look here. So patients with established CHF, fraction about 50. According to the Russian criteria of 2018, where BNP is not necessary, but echo is a must and other signs and symptoms are a must. So they confirmed the diagnosis in 80% of the cases. In using ESC 2016, only 37% had confirmed criteria. So not everyone who has CHF, HFpEF could be confirmed according to the criteria. And applying different criteria, we can see confirmation in different patient rate. So if we use ESC 2016, and this is the criteria which is, by the way, approved by the Russian Society of Cardiologists in 2021, and we use it in Russian now, the key thing here is BNP. BNP, what we should remember, current threshold, higher than 35 BNP in order to suspect, better to say, so less than 35 to exclude CHF. It should be high sensitivity, 95, 96, but low specificity. We understand that BNP can be increased, although there is no diagnosis of CHF. If we take higher threshold for BNP, we can increase specificity, yes, like here, but we immediately lose sensitivity. It's a price. That's why we understand that normal BNP mainly rule out, but not the rule in. And that's the challenge. Even here on the slide, we understand that with the sensitivity of 95, 96, if we see normal BNP, so in 100 patients with CHF, we make the diagnosis only in 5. So that's fantastic publication that shows that 29% of patients with symptoms of HFpEF and confirmed blood pressure in left atria, the levels of NT-proBNP was less than 100. So it's sometimes difficult to say yes or no, yes or no. We should always remember what are the reasons of increased BNP, why BNP can be increased or reduced. Well, many reasons to increase. Everything what can stretch left artery increases BNP. Also kidney function can increase BNP. But on the other hand, BNP can be low. Also with CHF, because obesity, because edema, because pericardial restriction, because lung edema, etc. And that is why updated ways were offered for diagnosis where BNP is not a must. First of all, this is H2FPEF, FPEF. So that's a special scale from Mayo. So that's invasive way. And here are parameters of physical examination, echo, and you can see all this. And this is the ratio E asterisk. And we should remember how to find these patients. First of all, is the dyspnea a feature of CHF or not? If not, you don't continue the examination. So it's something else. If yes, if we believe that dyspnea is CHF, then we use this special scale, HFA, PEFF. So BNP is not necessary anymore. It's one of the criteria that gives additional scoring, either rule in or rule out. So it appears to be, if we have low score by HFA PEF, then we exclude. If it's a high score, then we immediately confirm HFpEF, but in the intermediate, what we do is diastolic stress test. It could be as normal stress test in echo, but we assess not ischemia, but diastole. And if it is possible, we confirm CHF. If it's negative, then we exclude, we rule out. And then we try to find the reasons of specific reasons of CHF development, because it guides the treatment. Well, can these two ways coincide? Let's say American versus European? Not at all, not at all. They're far from each other. Look here, different patients are made diagnosis using these tools. So there is no consensus in diagnosis. There is no full understanding on how to make HFpEF. Let's go back to the European ESC 2021. They tell us, in case of HFpEF, they recommend objective data of increased pressure in left atria. And here is specific criteria. Well, simple criteria. And this is the index of left atria volume, also the ratio E asterisk. And it is not clear which combination of criteria can help us. I found two ways here. but you can follow anyone. In first option, any of these features is enough in the left atrium plus symptoms. In the second one, 2 or more. What if we take patients in 12 months after COVID? Well, we can take any other group. So let's take 12 months post-COVID. So depending on criteria for the HFpEF, we will make HFpEF to different patients. If we take criteria of 2018, where BNP is not necessary, so from 185 patients, 54 will be positive. If we take ESF 2016 criteria, only 23 patients, where BNP is a must. But if this is a criteria of HFA PFF, then there will be 24 patients. So that's very similar patients. 2021 criteria. So it's either echo picture or increase BNP, then make the diagnosis. Then from 181, we will have the same amount of patients like in Russian guidelines. And if we have another version where we need combination of parameters, so that would be only 20 patients and the same patients according to the HFA PFF, there would be just 4. So with that, I finish and give the mic to the next speaker. Dr. Mariev, thank you very much. Thank you very much for your presentation. Wow, you actually created the flood of questions on BNP and NT-proBNP, and we move on. I remind you that time of presentation should be approximately 7 to 8 minutes, because we have many presentations, long discussions, and already many questions. Well, we make next step forward. Now we touch kidney, and we come to CKD. We come to the issues that we face today and in the new era of CKD treatment. Now it's my pleasure to give the floor to Professor Babkova. Good morning, good afternoon, good evening, colleagues. Yes, today for the medical community, it's not a secret that CKD is a very serious challenge. We see that every 10th person has markers of kidney injury. And we understand that this is just the nephrology problem. No, this is not just the nephrology. This is mainly populational problem. And although we had some progress to reduce mortality from ischemic heart disease, from strokes, from obstructive pulmonary disease, whatever, we reached the reduction of mortality everywhere except CKD. No, CKD is just increasing because we increase diabetes, heart failure, and these are another populational problems, another diseases that are in the basis of CKD. And also what is a very serious challenge today is COVID pandemic. So, yes, we have issues of nephroprotection and cardio-nephroprotection because they are interrelated. Let me remind you that nephroprotection is the influence on general mechanism of progression that does not depend on the disease. And last 10 years, the focus was done on the main mechanism of unfavorable effects activated by RAS. So RAS blockade was very effective in cardio and nephroprotective. We use it for years to postpone the progression, to postpone the loss of kidney function, to minimize proteinuria, albuminuria, to reduce the risks of cardiovascular mortality, and at the same time, long-term use of RAS blockers showed us that it cannot give us more. We reached the ceiling. So RAS blockers gave us a lot, but this is not enough. There were some attempts of the full blockade and using combinations of inhibitors and blockers of angiotensin blockers, direct renin blockers, but no, we couldn't get more than what we have already got. That is why, if we look at the cross-section of our opportunities, you see that every study is assessing here, in any case, we see this or that residual risk, whatever we use, it's always residual risk of CKD. So we urgently needed something new, and this news came to us suddenly. It came from endocrinology. We never expected. But this light at the end of the tunnel was the new class of treatments for the treatment of type 2 diabetes, SGLT2 inhibitors. Kidney was not considered just the organ of target in diabetes, but also now we understand that this is a serious organ that is regulating metabolic processes and also can regulate systemic hemodynamics. So this is a new class, and they are blocking SGLT2, which are in proximal tubules. And this is a transporter of sodium and glucose. And it was done to reduce the reabsorption of glucose, to excrete the glucose. And this is how glycemia could be reduced. But it appeared to be that the effects were pleiotropic, and anti-glycemic effect was very moderate, but the other component, natriuretic component, could influence hemodynamics, could influence intraglomerular hemodynamics. And if before using the drugs modulating unfavorable effects using inhibitors RAS, we tried to modulate efferent arteriola, but now we can modulate efferent arteriola, afferent and efferent. This is how we can influence both the door to come in and the door to go out. And now we see that afferent, which is flow in, is equal to the efferent, flow out. That's why SGLT2 inhibitors are very, very beneficial. And this is how we can regulate inflow and outflow. That means this is how SGLT2 inhibitors can provide additional protection of kidneys, influencing intraglomerular hypertension. But let's look at natriuretic effect. This is also systemic effect and intraglomerular dynamics. This class of treatments could influence the mechanisms of inflammation and the development of tubular interstitial fibrosis, because that's the basis of CKD progression. And this is important, not only glomerular sclerosis, but also we should look at the fibrosis. So these drugs, they reduce RAS activity, they reduce markers of inflammation, they reduce fibrosis, they improve oxygenation in tubules, they reduce transport of diluted substances and increase the delivery of oxygen. They also stabilize GFR and albuminuria, they reduce albuminuria, they reduce arterial blood pressure, they reduce damage of canals and tubules, reduces ischemic kidney injury, and increases hemoglobin and hematocrit. So also they influence uric acid, which is very relevant for patients with metabolic syndrome with hyperuricemia. So it appeared to be that this class of drugs is not just for the diabetes. No, it's pleiotropic and much more extended effect. And here you see the clinical program of using dapagliflozin as one of the representatives of this class for the prevention of type 2 diabetes and CKD. Well, primarily they were diabetic patients, and this is very clear because the drug was designed for the treatment of diabetic patients. But if in all the studies they mainly looked at the combined endpoint, MACE, major adverse cardiovascular and renal events, but a very serious breakthrough, kidney breakthrough, was DECLARE study with dapagliflozin. And DECLARE included patients with not yet established cardiovascular events. So they were patients with risk factors of cardiovascular complications. So that was pretty big group of patients with normal GFR, and it appeared to be that in such high-risk group patients, the assessment of the effect demonstrated fantastic results. We managed to reduce the renal endpoints by 47% and reduced the risk of heart failure progression in patients with baseline good renal function. So only risk factors. So we can preserve renal function, and we can see some preventive effects of dapagliflozin for the development and further progression of nephropathy. It is a very important result shown here. The cardionephroprotective effect even does not depend on glycemia. So it works in all spectrum of glycemia, very low, moderate, or in high glycemia. So, and that is why these effects were also tested on the group of patients without diabetes. And that was a revolutionary study, DAPA-CKD. It included very diverse patients group, 68% with diabetes, 32% without diabetes. And here we already saw the patients with albuminuria. We see patients with estimated GFI in the big spectrum from 20 to 75. So in this population, dapagliflozin dramatically reduced the risk of primary endpoint, combined renal endpoint, very serious endpoint, which is a sustainable reduction of GFR more than 50%, end-stage renal disease, and renal or cardiovascular mortality. So this endpoint was reduced by 39%, and number needed to treat was just 19. So treating 19 patients, we can minimize one component of the endpoint. And you see how these curves are splitting. They split almost from the very beginning. So we can get this effect very fast, very fast. And this is really very serious effect, and it's even better than other heart failure treatments. Dapagliflozin reduces also all-cause mortality and reduces cardiovascular risks and CHF hospitalization, heart failure hospitalization. So that's complex cardio and nephroprotection was seen in a mixed group of patients with CKD, with and without diabetes. You see the curves are splitting very early. So you start and you see the effect almost immediately. Now we have much bigger evidence-based data for SGLT2 in CKD patients without diabetes. We enjoy some other studies, and the most important, and today we will speak about it later, that dapagliflozin demonstrates very good safety profile. And we were very much afraid of some adverse events, but it was not confirmed. So we can say we provide 3D protection, complete cardiorenal protection for patients with diabetes, with CKD, with CHF. We can reduce the risks of hospitalizations, and we can definitely improve all the endpoints. So we can provide renal protection in patients with CKD of non-diabetic nature, and also chronic heart failure in patients with CKD, with and without diabetes. Thank you very much for your attention. Please share your screen, Professor Seferovich. Please share your screen.
Yes, I will share my screen now.
Thank you very much, dear Professor Babkova.
Okay,
You spoke about important results.
Note.
Full screen, please.
Yes, please. Okay.
So, it's a very serious step for medicine. For many years, we were using old groups of treatments without new opportunities. Yes, now new directions are developing, anti-inflammatory strategies, etc. But the key one here is the use of SGLT2 inhibitor, dapagliflozin, in this group of patients. And now it's my great pleasure and honor to give a floor to our distinguished guest, fantastic guest, Professor Petr Seferovich. Mike is yours. Please speak up.
Thank you very much. It is my great pleasure to be here. I was participating at several meetings of the Eurasian Association for Cardiotherapy, and I am happy to be here with you. So I will be brief and straightforward. This is Heart Failure Association Atlas, our first insight on the heart failure epidemiology and management in heart failure, in whom we understood that the main median annual incidence of heart failure was 3.2 per 1,000 person years, and median prevalence of heart failure was 17.2. So these are the first data, epidemiological data from the European ground, in whom we are able to exactly see how the things are going. The mortality of heart failure, but also the very frequent condition. So when we are talking about heart failure, we are talking about the spectrum of diseases in a different ejection fraction, heavily influenced by comorbidities and different disease modifiers. And that's why it's hard to treat this disease, but we were lucky enough to have now SGLT2 inhibitors. DAPA is very prominent, which is going to give us the possibility to treat both forms, HFpEF and HFrEF. As it was already discussed, the mechanism of cardionephroprotective effect is complex. The reduction of the preload and afterload, which was not mentioned before, then myocardial energetics, which is extremely important, and the renal effect, which are essential in order to provide the best understanding of the positive clinical effect of those drugs. So we had several experiences with dapagliflozin. DAPA-HF was one of the most important SGLT2, but also heart failure trial ever, with 4,742 patients, in whom we clearly demonstrated a significant reduction of cardiovascular death and worsening heart failure in patients with HFrEF. So what is even important, and what we may discuss later, are the very early effect of dapagliflozin, which started at the day 28. All-cause mortality was also reduced, giving us the possibility to think that we have extremely powerful drugs in our hand. However, this is not the end of the story, because we recently learned that the liver, the largest and the broadest trial to date in patients with left ventricular ejection fraction more than 40, went into life with more than 6,000 patients, giving us an excellent overview of very complex patient groups. As you can see, these patients are older, very symptomatic, with elevated risk, with high rate of comorbidities, and within the well-represented left ventricular ejection fraction groups, giving us the possibility to conclude that we are dealing with a real drug which acts in the HFpEF environment. The results were spectacular, and because dapagliflozin significantly reduced the composite endpoint of cardiovascular death or worsening heart failure, with 18% relative risk reduction. If we look at any individual component, it is clearly that dapagliflozin was extremely effective in reducing cardiovascular death, but also worsening heart failure and urgent heart failure visit. So if you look at the plot, you can see that dapagliflozin was more efficient in any of the secondary composite endpoint group. This consistent treatment benefit stayed across all pre-specified subgroups. I'm convinced that we are going to discuss this within the frame of our discussion panel. It is important to understand that that looks more than like dream than like the reality, because having such a positive benefit across all pre-specified group was the wish of clinical trialists all time. The drug was extremely efficacious also in the patient with improved or recovered left ventricular ejection fraction. This is extremely important because this group was increasingly recognized as a very important dynamic group, in whom we have the patient who are transferring to the both sides, to the better or to the worse. Dapagliflozin was extremely efficacious in all these settings. Secondary endpoints were shown here, including the change in KCCQ TSS at 8 months, which once again confirm an excellent functional capacity improvement in the patient with dapagliflozin. Also, what was clearly shown is that the safety and tolerability of dapagliflozin, not only in the liver, but also across all dapagliflozin trials, was excellent, with side effects being even less frequent than with placebo. So this is the drugs we were always dreaming of: high efficacy and low side effects. I know that Professor Miloradovic will speak about the combined effect of dapagliflozin in a different group, But I just would like to point it out once again that comprehensive meta-analysis of 4 randomized SGLT2 inhibitor trials clearly shown that this is an extraordinary group of the drugs, giving us the possibility now, for the first time in human history, to treat patients with both HEF and HFpEF and HFrEF. The safety profile of those drugs were excellent, and therefore we are very much in favor of implementing this all over the world, and especially in the big country like Russia. We go on the other side of the ocean, and this is the trilateral cooperative project of the Heart Failure Society of America, Japanese Heart Failure Society, and the Heart Failure Association. We can clearly see that the guidelines on the both sides of Atlantic are priced SGLT2 inhibitors as the first drug in the treatment of HFpEF and HFrEF. There are some differences, but these differences are mostly due to the different social environment in those continents. Therefore, ESC guidelines for the treatment of acute and chronic heart failure and 2022 American Heart Association and American College of Cardiology guidelines in one sentence are in complete agreement that SGLT2 inhibitors could be one of the 4 drugs which are using at the mainstay treatment of our patient. Even more, drug treatment of HFpEF, according to the American guidelines, which came a little bit later, and that's why put SGLT2 inhibitors on the first place, giving us the possibility to see SGLT2 inhibitors as a major game changer in this field. We may say that we don't have only the new drugs, but also the new strategies. And if we would like to underline those strategies, is the use of quadruple instead of triple medical treatment, simultaneous instead of sequential introduction of the drug, and also patient profiling and strategic phenotyping. Treatment pairing directly connected with strategic phenotyping is extremely important. It comes to the therapeutic initiation of the different drugs very early, trying to put the speed on the first place, giving us the possibility that we start with more drugs in the matter of a few weeks rather than a few months, taking into account the patient characterization and initiation and up titration of the must-have drug. So that is giving us the strength to conclude, and that comes from the close trial analysis of EMPhASIS-HF, PARADIGM-HF, and DAPA-HF, that using the comprehensive instead of conventional treatment will prolong the life of our patient for 8.3 years, which is amazing and which we need to take into account. Ladies and gentlemen, dear friends, the game is not over. We have many more things to learn about SGLT2 inhibitors, and one of the leading SGLT2 inhibitors is DAPA. We look forward to the next trials in whom we are going straight forward to understand what is the final border in heart failure in whom we may use this kind of drugs. What you are seeing now is the evening of January 23rd, 1896, when Professor Rengen at the University of Würzburg demonstrated for the first time use of X-ray photograph. I don't want to make any comparison between the discovery of SGLT2 inhibitors and X-ray, but it seems to me that SGLT2 inhibitors are the game changer and that we need to work all together. And this is a big challenge on the implementation of this drug. Thank you very much for your attention.
Профессор Сеферович, Огромное спасибо за ваши...
Professor Tseferovich, thank you very much. Fantastic. Professor Miloradovich, please share your screen. Please share your screen. So many thanks to Professor Tseferovich, and also many thanks to our interpreters for very emotional translation. And we move on. And the next presentation will deal with the issues of SGLT2 inhibitors. So this is augmented reality, opening the full spectrum in the treatment of patients with CHF. I think the presentation of Professor Tseferovich created the flood of questions about the phenotyping of the patients, CHF of different etiologies, CKD of different etiologies. So phenotyping is very, very hot issue now. But now we are moving to the high-speed session, and my pleasure to give the mic to Professor Miloradovich. Please start.
Thank you for your invitation. I'm very pleased to be with you today. Dear colleagues, the panelists, the auditorium. In the next few minutes, I will present to you a pooled analysis of two landmark trials with dapagliflozin, DAPA-HF trial and DELIVER trial. This prospective patient-level pooled analysis included more than 11,000 patients. The main purpose was to examine the effect of dapagliflozin across the left ventricular ejection fraction range, given the attenuation seen in patients with higher left ventricular ejection fractions in all other heart failure medication trials, such as EMPEROR PRESERVE trial with dapagliflozin. And when we looked at the effects, they were included, they were estimated through pre-specified outcomes such as cardiovascular death, all-cause death, total heart failure and first heart failure hospitalization, and MACE like cardiovascular death, MI, and stroke. And on the end, on the composite effect of cardiovascular death or heart failure hospitalization. And when we're talking about the first pre-specified outcomes, such as cardiovascular death, we can clearly see significant reduction of 14% in the group of patients on 10 milligrams of dapagliflozin. The p-value was 0.09, and this result was statistically significant. As we can see, both of the trials contributed to significant reduction of cardiovascular death, and there was no heterogeneity found in these results. Besides statistically significant reduction of cardiovascular death, we can see the reduction of all-cause death for 10%. P-value was 0.03, and that result reached borderline statistical significance. And when we're talking about reduction of heart failure hospitalization, first and total, we can see reduction of 26 and 29%, and both of these results reached highly statistical significance. And reduction of composite effect of cardiovascular death or heart failure hospitalization was 22%. And what is the more important, all of these results were consistent to whole spectrum of left ventricular ejection fraction. In a summary of dapagliflozin use across the left ventricular ejection fraction range, we can see significantly reduced all pre-specified outcomes: heart failure hospitalization, cardiovascular death, all-cause death, and composite effect on cardiovascular death or heart failure hospitalization. And it's no difference of the effect of dapagliflozin with increasing left ventricular ejection fractions for any of the pre-specified outcomes. And on the end, when we're talking of this pre-specified patient-level pooled analysis of two landmark trials who examine the effect of DAPA across the left ventricular ejection fraction range through pre-specified outcomes like cardiovascular all-cause death and first and total heart failure hospitalization, MACE, and composite effect on cardiovascular death and heart failure hospitalization, we clearly see that all of these outcomes were significantly reduction, and what is more important, in whole spectrum across the left ventricular ejection fraction. And in my conclusion, SGLT2 inhibitors, including dapagliflozin, recommended in patients with heart failure regardless of LVEF. And unfortunately, guided directed medical use, including SGLT2 inhibitors, is suboptimal now. The liver and DAPA-HF demonstrated significant benefits of dapagliflozin across the range of left ventricular ejection fractions. These pooled sub-analyses demonstrated consistent effects across the whole spectrum of ejection fraction on all of these pre-specified outcomes who reached statistically significant reduction of, I repeat, cardiovascular or all death and heart failure hospitalization first and repeat, and of course, composite effects on cardiovascular death or heart failure hospitalization. And as we know, SGLT2 inhibitors with clinically meaningful mortality benefit in patients with heart failure across the range of left ventricular ejection fraction is dapagliflozin. Dapagliflozin is now a key component of guided directed medical therapy in patients with heart failure, regardless of left ventricular ejection fractions. Thank you for your attention.
Спасибо вам, профессор Милорадович.
Thank you very much, Professor Miloradovich. Thank you very much for pooled analysis and for the demonstration of very obvious fact now. Any patient with CHF, so no matter what is ejection fraction, everyone should get this life-saving treatment, dapagliflozin. But when we say that something is effective everywhere, we should also speak about the safety. Yes, you mentioned the answer to that question as well, together with Professor Seferovich. But now let me invite Professor Petunina for separate presentation about the safe use of SGLT2 inhibitors. We will speak about the safety profile. Well, there are many meta-analyses which are covering the issues of safety of using SGLT2 inhibitors as the class and the separate SGLT2 inhibitors. We know these arguments about safety in the development of urogenital infections, and not only candidosis, but I'm speaking about infections, and there was some criticizing of meta-analysis that did not include patients who had relapsing urinary tract infections or asymptomatic bacteriuria. And when we exclude these patients, we deviate the results. But whatever the argument it is, now we understand that the benefits of SGLT2 inhibitors are much higher than these risks. That is why, in order to open the issue of safety, I give the mic to the next speaker. Good morning, good afternoon, and good evening, distinguished dear colleagues. Well, we know very well that the issue of safety was, is, and will be always very important. It is not less important than the issue of efficacy. In the history of medicine, we have examples when some drugs were out of the markets or representatives of particular class or the whole classes due to this disbalance of risk and benefit. For us, endocrinologists, these are the stories of obesity treatment. What can we say about SGLT2? And here on the slide, you can appreciate the advantages, and we have no doubt about it, and also the issues of safety that were actively discussed from the moment when this class came to market. So this is position of Russian Association of Endocrinologists of 2019. So you see the list of advantages on the left, the green list, but also we have the issues about the safety and tolerability. But now, after the years of use, we understand that risks we were thinking about became myths, but other issues like acute kidney injury, Fournier gangrene. So there was the evolution of understanding, and now we don't discuss these risks. So we now speak about protective effects of SGLT2 inhibitors, although not everything shown here on the right is a myth. Yes, there are some real risks, and I would like to mention them briefly in my short presentation. Now let's refer to the position of the document, which was updated in September this year. This is consensus of American Diabetic Association and European Group for Diabetes Studies, ADA and ESD. So they are showing position about safety here, and I'm showing in red here. They say that in the dynamics of their assessments, they are now more confident in safety of SGLT2. They are more confident. Well, it could be the end of my presentation, but let me characterize briefly the risks that we potentially can see, and they are not myths. Yes, urinary tract infection and genital infections, it can happen, and we have to split them. Speaking about the urinary tract infection, UTIs did not show any increase of these risks of UTI, but the drug came to market and it was started in diabetic patients. We should not forget that diabetic patients are initially a risk group for the development of urinary tract infections. And that is why we have this recommendation. So this is assessment of urinary tests, and we should administer uroseptics if we identify features of bacteriuria of the infection, and only then we can administer SGLT2 inhibitors. Now speaking about genital infections. Well, here we see some risks, and in all the studies, the rate of genital infections was higher versus placebo. And this is for everyone, for CANA, DAPA, EMPA, and ER2. But we should speak about the separate risk groups. These are gender specificities, and anatomically, the high-risk group are females. Then, initially, there are patients who are prone to genital infections, so we should collect medical history, and if there are more than 3 episodes of genital infections a year, then probably this patient is not the ideal candidate for SGLT2 inhibitors. These are definitely patients with severe decompensation of diabetes because of mode of action, and pharmacological glucosuria could be more massive, increasing the risks of genital infections. But there is a good solution. Keeping in mind all the advantages, we clearly understand that hygiene, and again hygiene. You should speak about it with the patients. Also, vast majority of cases for the development of the genital infections are mild or moderate, and it does not require discontinuation of SGLT2 with the standard treatment of antifungals, local, topical, or systemic if needed in the classical schemes. Of course, if this is a severe relapsing infection, then we should ask a question about the discontinuation of SGLT2. Definitely, it should not be continued in case of relapsing and severe genital infection. But all in all, distinguished colleagues, definitely, speaking about the pagliflozin, speaking about the large-scale trials that were carried out, we should confirm that this is fantastic safety profile that we never expected. And looking at the risks that were initially mentioned, fractures, bladder cancer that initially was discussed, amputations, Fournier gangrene, acute kidney injuries, well, that's absolute relief. We see complete safety here, and these arrows going up refer just to genital infections and diabetic ketoacidosis that I would like to say a few words later. This is DAPA-CKD study, and it allowed us to compare the safety among the patients with and without diabetes, patients with CKD. And also we see very good safety profile, which is more than affordable and appropriate. So a bit more frequently, we could see these risks or these side effects in the group of patients suffering from diabetes. But if we look at placebo group, and then if we compare it with the group of DAPA and without diabetes, so once again, we can be absolutely sure that the risks are mainly associated either with diabetes that is prone to genital infections and urinary tract infections. Speaking about other points of interest, DAPA-CKD also gave answers to all the questions from the position of safety. You can appreciate here, risks of amputations are minimal and compared to placebo. Now, side effects, kidney side effects here in the group with CKD, well, we see not high risks, there is very good renal protection and unprecedented safety of risks of hypoglycemias, and in patients without diabetes, hypos were not reported at all. DAPA-HF, patients with CHF, with the use of dapagliflozin, both in and without diabetes, with and without diabetes, also demonstrates fantastic safety profile with the same confirmation of safety about the risks of hypoglycemia and other potential complications of special interest. Now let me go back to ketoacidosis. And here we need to say that truly these cases were reported in all molecules of the class. Yes, this is very rare but very severe complication. And until now, we can say that SGLT2 inhibitors, they are masking the development of ketoacidosis. They don't cause it, but they mask it, because this is a special form of so-called euglycemic ketoacidosis. But at the same time, we should remember that ketonuria could associate administration of SGLT2 inhibitors pretty frequently, and this is not a risk. So who are these patients who can have a risk for ketoacidosis? The main reason is insulin deficiency. And if there is a severe reduction of dose of insulin in those patients who are in insulin treatment, especially with acute infections, could potentially provoke the development of ketoacidosis here. And first of all, we need to keep it in mind. And we know that in a vast majority of cases, descriptions are related with so-called slow progressing type 1 diabetes, slow progressing type 1, and this is very important. So, with a severe disease, with dehydration, with vomiting, with diarrhea, it is recommended to interrupt SGLT2 inhibitors. And actually, in such a case, we need to pay attention to the label and follow the label. In massive surgeries, let's say in 2-3 days, we can temporarily stop SGLT2 inhibitors and restart after the surgery. But if there were cases of DKA in the medical history, so these patients are not the best candidates for such inhibitors. Now, amputations. Well, this story happened because of Canvas and Canvas 2 with canagliflozin, and this is a black warning box which was made by FDA, although further follow-up actually made rehabilitation of both canagliflozin and other representatives of the class. So there is no risk of amputations, and such disbalance was not reported anymore. But nevertheless, again, speaking about diabetic patients, the examination of feet is adequate and obligatory procedure. And if there are infective ulcers, definitely we should interrupt temporarily SGLT2 inhibitors. And fractures, as well as other risks, appear to be myths. And first, they were in the document of American College of Endocrinologists 2018 as a characteristic of this class. In 2020, you don't see this risk anymore. They deleted it. And wrapping up, well, first of all, I would like to emphasize that SGLT2 inhibitors are unprecedentedly safe for hypoglycemias as well. They have insulin-independent mechanism of action, and they never compromise other functions. So no hypoglycemias. Hypo could be a case only in combined treatment, normally with insulin and sulfonylureas, and possibly these doses can be corrected with SGLT2 inhibitors, but again, this decision should be made individually. So, wrapping up, distinguished colleagues, I would like to finish my presentation and to emphasize that the clinical advantages are much bigger over all possible risks, which are not myths. And these are risks of genital infections mainly. And here we have very clearly designed preventive rules for the prevention and treatment that can and should be applied. And definitely risks are minor. The risks are very minimal. So this class of treatments has very good safety profile, very good tolerability, and it should use much wider. Thank you. Professor Petunina, thank you very much. And I would like to quote the huge number of gratitude that we obtained after your presentation. These are words of support. That's a gratitude for very well-balanced and rational approach, not the negativism towards adverse events, but very well-balanced approach for SGLT2 prescription. And we are moving on. So we spoke about safety, we spoke about CHF, we spoke about CKD, but you should agree that the topic would not be complete without the last presentation. Let me remind you, in my first presentation, I reminded that a significant number of patients with CHF can have acute kidney injury, up to 20%. So the presence of acute kidney injury, AKI, actually puts the patients on the crossroads. We don't know what happens next. Worsening of CKD, acute kidney disease, or maybe mild worsening within 3-4 days, and then normalization of creatinine and GFR would not react to that. We don't know, but we know for sure that the episodes of acute kidney injury could happen. And within life, it can happen with everyone. But for us, it's very important to understand what would be their role in the prognosis of CHF patients with CKD, and how we can minimize these risks. And now I'm happy to give the floor to the final speaker, Professor Fomin, about the acute kidney injury in hospitalized CHF patients. Dear colleagues, dear friends, I am pleased to be the part of this expert panel. So the risks of acute kidney injury in patients with CHF. So why do we start talking about this issue specifically? In the world, there are very many elderly patients. The world is aging. So there is very high stratification risk. So these are lonely patients, patients with CKD, because they are increasing in their numbers. Also, another thing is that we have more and more aged patients and comorbid patients at the end. And now we have 3 diseases. And then if there are 3 diseases, so the risk of AKI increased 8 times. And definitely our policy, normally we are quite aggressive medically and surgically. So this aggressiveness also increases the risk of acute kidney injury. So I'm not going into the classification, you know that, but I have to remind you that in terms of timing, the intensity of creatinine increases associated with AKI, it's up to 2 times, that's stage 1, up to 3 times, that's stage 2, and more than 3 times increase, that's stage 3, increase of creatinine clearance. This is stage 3. Another important thing, in 3 months, in 12 months, we need to recheck the patient and then to say what happened to the patients in order to understand the reason. Why? It's all very simple. So the studies show us that if we discharge the patient, that in average, those patients that have pre-hospitally acute kidney injury, this is association with chronic heart failure, then 30% of the patients would give us CKD de novo. And then they can confirm it. And what is very important, they could demonstrate the worsening of the kidney injury. Another important things, the risks of mortality are pretty high, and they could be seen within first 1.5 years. And this is a trigger for the worsening of the prognosis. When and why? Within a year, we have more or 2 episodes of acute kidney failure. At the same time, we could see that there is a dramatic increase of probability to reduce the GFR rate in this category of patients. Looking on the right here, we could appreciate a pretty significant link between the stage 1 of kidney injury and the progression of kidney injury, so-called U-shaped curve, U-shaped curve. So in any cause of filtration, you can see it. The triggers are shown on the right. So everything that is mentioned here, this is polymorbidity, the doses of diuretics, the dose of ACE inhibitors, or the combination with RAS blockers, with angiotensin receptors blockers. Also, low compliance of the patients plays a role, infections, arrhythmias, and anemic syndrome. At the same time, it is quite logical. So acute decompensation of heart failure, then it is actively associated with acute kidney injury, and it significantly increases the risks of mortality. And if we see 2 or more acute kidney injuries that happens, then there is 1 month, just 30 days, in order to increase the risk of cardiovascular mortality. So now we clearly understand that acute kidney injury is changing significantly the course of CKD, could lead to the progression and leads to the end-stage renal disease. The other important here, this is also the treatment of diuretics, and another important is hemodynamic aspects, and active dehydration of the patients also plays a role. Now, let's share therapeutical activities. So today we speak a lot that ACE inhibitors should and can be used, but they can increase the risks of AKI. And all RAS blockers versus the control, so an average in 50%, they increase the risks for acute kidney injury. Yes, sartans, they are a little bit weaker than ACE inhibitors, but another important thing, standard doses of ACE inhibitors in case of long-term treatment could increase the risks of dehydration of patients. And another important risk, they increase the risk of acute kidney injury, which is, dear colleagues, associated with polymorbidity of the patients. And there are some other triggers here, which is cancer, dementia, and also we understand that this association and the creation of acute kidney injury by inhibitors is actually a very active and frequent story, and so probability increases in 2.5 times, so in this condition. So here, KDIGA 2021 provided the changes of the strategy in the patient management with ACE inhibitors. So please appreciate here, almost all the treatments, all ACE inhibitors, they significantly reduce the doses if creatinine clearance starts reducing. And in this case, only one alonaprin has actually BID indication, so has absence of dose correction. So we understand clearly that ACE inhibitors, they are associated with the fact that mainly they're excreted through the kidneys. Sartans, they are mainly excreted through the liver metabolites. So we believe that risks for sartans would be much lower. This is the study of the patients with preserved ejection fraction. So please appreciate, within the first 2 months, they have increase of risks of kidney injury with the maximum dose of sartans twice. So this is very logical. We are asking a question, can it influence the life prognosis of the patients? So here on the right, we see the risks of cardiovascular mortality and hospitalization. And at the beginning of the year, in fact, it is the dose which is organ protective. But later on, we see the escape syndrome, and also at the end of 2.5 years of treatment, we could appreciate that the prognosis of life of the patient that have maximum dose of sartans and has the high risks of acute kidney injury could increase the risk of mortality by 75%. So this is dramatic increase. Those patients who have no acute kidney injury, they dramatically improve the prognosis of life versus placebo. So this is how in sartans we also enjoy fantastic situation. So we have clear understanding that both RAS blockers and the combination of RAS blockers plus mineralocorticoid receptor antagonists, they could increase the risk of acute kidney injury. But what about anti-glycemic treatments in type 2 diabetes patients? Actually, we heard today that the inhibitors of SGLT2 inhibitors, they are priorities in this case. And please appreciate here, we see that here are SGLT2 inhibitors, they are beneficial in the prevention of acute kidney injury, and they are much more beneficial versus other comparators. So we can say that main triggers have already been discussed today. And actually, I love this phrase. What is important is not the AKI itself, but the consequences where it develops, or something that causes the reason, and it creates the prognosis. So we understand that the inhibitors of SGLT2 are extremely effective, and they are fighting with ischemia. They could prevent hypoxia of the kidney due to the increase of hematocrit. They could optimize the myocardial function, and this is how they can increase the ejection fraction, and this is how they prevent hemodynamic and other types of changes in the kidneys. And the reduction of dose of diuretics allows us to prevent acute kidney injury, and definitely it influences the aseptic inflammation. So this is DAPA-CKD study, which proved that within 2 weeks, the curves start splitting here, speaking about the prevention of acute kidney injury. And please appreciate the risk reduces by 31%. This is significant. So today, the experts are coming to the consensus position. The use of SGLT2 inhibitors is safe about the iatrogenic reasons of the increased risk of acute kidney injury in patients with high cardiovascular risks, in patients with type 2 diabetes, in patients with heart failure, in patients with severe albuminuria, and patients with treatment of diuretics. With that, I thank you very much for your attention, and if you have any questions, you are welcome. So, dear experts, please activate your cameras. Activate your cameras. We move to the Q&A. Well, all our experts made their presentations, and now we will see all the experts on the big screen, so please smile. And we are coming to the most interesting part, the juiciest part, which is not easy part, and this is a discussion. Well, the questions we are getting now in the chat, they're very different. They're extremely different. And this is the burst of the question. And I'm pretty sure that positions of the experts could be very different. But now in discussion time, we will try to find some common grounds. And now I'm referring to the 1,500 audience, 1,500, oh, now 1,600. Technicians tell me 1,600 people are connected now. So don't hesitate. Provide your questions, comments, remarks. We will give the answers now or sometime later in our Telegram channel.
Could I say something at the beginning?
Just a moment. They will ask questions. Just a second. The
Okay.
first question is to Igor. We got it before your presentation. Question to Professor Fomin. And when we speak about DAPA-CKD, so they mentioned doubling of creatinine, but doubling of creatinine is stage 2 of acute kidney injury. So what can we say about the first stage of acute kidney injury by Akin or KDIGA using SGLT2 inhibitors? Professor Fomin? Is it question to me? Yes, the question is to you. I thought that was a question to Peter. Well, could you repeat the question, please? The question is, the question was received before your presentation. So in your presentation, you mentioned DAPA-CKD, and there was a risk reduction of acute kidney injury, and this is doubling of serum creatinine, but this is stage 2 by Akin or KDIGA. What could you say about stage 1 of acute kidney injury? Well, dear colleagues, we clearly understand that probability of stage 1 would be higher. Stage 1 of acute kidney injury. And all studies speak about the U-shaped curve. This is parabola, but we also understand that stage 1 is not changing the prognosis of the patients, because most frequently that happens as a recovery. With the stage 2, the probability of myocardial injury and the worsening of kidney is much higher. The risk is much higher. That is why stage 2 is considered to be a priority. Stage 1 is reversible. And in order to respond to kidney injury, we need to analyze the patient exactly in 12 weeks, not earlier, not later, 12 weeks, because possibly we can see recovery within this within this period. Thank you very much. So in fact, we can say that grade 1, it can be more frequent, but we can neglect it because it's a high probability of reversible. So 26 micromole a liter, that's the drop of creatinine. Yes, just a second. I will tell you, if during 12 weeks we cannot stabilize the cardiac function, that means we cannot get the control over heart failure, then the probability of more severe stage of acute kidney injury is increasing. Because please appreciate here, this is not the acute kidney injury that worsens the prognosis, not the injury, but the system of risk factors, of comorbidities, which we are not controlling. If for 12 weeks we cannot get control, then we will see more severe acute kidney injury. That leads to more severe CKD later on. Thank you very much. My next question to Dr. Mareev. Yuri, you mentioned the role of BNP and NT-proBNP in the diagnosis of heart failure. And now it's a question about sacubitril valsartan, ARNI. We see it more and more frequently for hypertensive patients, so it influences NT and NT-proBNP. So how shall we assess BNP if with ARNI BNP is increasing? Well, the increase of BNP with ARNI, well, I think it's a myth. It's a myth. We clearly understand that if we provide sacubitril valsartan, it's better to use NT-proBNP, because if we look at BNP, well, at first moment, BNP can be increased a little bit, but still, sacubitril valsartan is effective for CHA, and then NT-proBNP would be reduced, but don't think that BNP would be great. It would reduce, but not immediately, because finally we will compensate CHF and BNP would be normal. Well, thank you very much for the clarification. And my next question to Professor Tseferovich. Dear Peter, the question is provocative. If we say that nephroprotective effect is a class effect, and we can bravely use not only DAPA, but any SGLT2 inhibitors for nephroprotection for CHF patient, can we say the same, that any SGLT2 could be administered to the patient with HFpEF? Thank you.
So thank you very much. But as you may see, I'm a very experienced lecturer, so the question is provocative, but the answer is very clear-cut. What we are doing, we are judging the effect of any drug according to the clinical trials we have. We have the clinical trials of dapagliflozin, and we have clinical trials of empagliflozin. So we go straight forward with both CKD effect, which is extremely important, and the effect on HFpEF for both DAPA and empagliflozin. However, don't be confused, because this is one or many million-dollar question you ask, and we are the scientists. And we need to have in our mind straightforward decision-making process based on evidence-based medicine. And therefore, my answer is straightforward and very clear, and is based on the clinical trials we have. If you remember the one before last slide I showed, this game is not over. And usually in my SGLT2 lectures, which I have all over the world, and after the completion of the COVID era, I have more than 30 lectures all over the world, from Japan to the South America, about SGLT2 inhibitors. I am always showing the slide when Heart Failure Association in the early 2019, it was March 2019, published a paper about the SGLT2 inhibitors, showing that this drug may be not only anti-diabetic drug, but also heart failure drug. At that time, we discussed within the leadership of Heart Failure Association what will be the best to do. And both delivered and emperor preserved are the results of those discussions. So you need to understand that we are facing the breakthrough in the treatment of heart failure. That now we are much powerful than before in any sense. We mentioned here HFpEF and HFrEF, but we did not mention the worsening heart failure. And as you know, SGLT2 inhibitors are very powerful, both EMPA and DAPA in this setting. And we need now to understand that these drugs will change the course of the heart failure, giving us the possibility to treat our patients much better, and giving them not only the longer survival, but also better functional capacity.
Спасибо большое за развернутый ответ.
Thank you very much for a very comprehensive answer. I will make a small remark. So this is International Congress, and we have participants from different countries. And if there are some limitations in the label of the drug, then please clarify the country, because the labels in different countries could be very different. And definitely there are some limitations. But this is International Congress. We can speak on every issue. But for example, in some countries, it could be yet off label. Yes, it could be the case. Now, my next question.
Before we continue, I would like to add something if possible.
Please, you're welcome.
Okay, so what is important for us to understand that we are facing a revolution in the treatment of heart failure. Most of the viewers, since this is International Congress, but there are some also Russian audience, they know that I know the Russian Heart Failure Society very well, and that we spend a lot of time trying to think how we are going to implement all this, because scientific proof is very strong. And we know that these drugs should be given to all of our HFpEF, HFrEF patient, but also the patient with renal dysfunction. And the question is for everybody here, how to implement the use of this drug in terms of clinical phenotyping. Why I'm saying that? Because this is the most important part of our game. So we have the drugs which start early, does not need any up-titration, has an excellent efficacy, and has no side effect. So this is extremely important to understand, because in the phenotyping, this drug can be always the first one. So clinical phenotyping is based on the patient characteristics, but none of those characteristics can preclude giving the SGLT2 inhibitors. So I think that this is the major, that should be the major message from this symposium, giving us the possibility to put forward and to think in every country, and Russia is a big country. For instance, in Serbia, we organized several discussions trying to put that very much so into the pens of not only cardiologists, but also internal medicine specialists and general practitioners. And that is something which we need to understand and which we need to work on.
Professor Seferovic, огромное спасибо за
Professor Seferovic, thank you very much for a very valuable comment. I see the hand of Professor Mariev, but let me say a few words first. Yes, we tell administer to everyone, but then let's answer the question when. When? because we discussed decompensated patients and we discussed stable patients. We discussed acute kidney injury, and then we should give very clear guidance when, let's say at hospital stage, when can we initiate SGLT2 inhibitors to the patients that never got them before. And if for sacubitril valsartan we have clinical data, but for SGLT2 inhibitors we don't have this data yet. So, and I think this question is still open. Yes, we tell to everyone as early as possible, but the question is when, and yet there is no trial giving answer to that.
All of you know that Piotr Ponikovsky was doing an Impulse trial, and there are trials also with the dapagliflozin, which will be completed soon. So it seems that DAPA and EMPA should be given as fast as we stabilize the patient. Depends on what type of worsening of heart failure or let's say cardiogenic shock or acute pulmonary edema the patient is presenting with. But the major message is that these drugs are very effective even in the setting of the worsening heart failure. And you know that around 60% of these patients are actually the worsening of chronic heart failure. And in those settings, if the patient is not on the SGLT2 inhibitors, he should be given that early during the course. And I don't want to go too far into the explanation, but I think that the congresses like this one and the congresses in the European Society of Cardiology and Heart Failure Association should transfer the big messages, important messages to everybody.
Спасибо огромное. Я вижу, что поднята
Thank you very
рука.
much. I see the hand of Professor Mareev, but let me say a word. Yes, of course, Professor Fomin, you're welcome. Well, I think for EMPA, we have already studied, and this is the same criteria like Pioneer study for sacubitril valsartan. So they showed high safety, improvement of quality of life, and improvement of the prognosis. So I think we can say that still we are in the area of hemodynamic stability after acute decompensation is when we stop IV diuretics for 6 hours and we switch to Peros, then 24 hours no ionotropes, 6 hours no vasodilators, and hemodynamics is stable and pressure is higher than 100 for 6 hours. So I think this is the criteria. This is the criterion which is the starting point where we can start thinking about SGLT2 inhibitors. Thank you. Thank you very much, Professor Fomin. Very valuable comments. And the discussion we just had with Professor Seferovich forces me to tackle another question, also very deep and thrilling question. Well, today you mentioned Professor Ponikovsky, very famous expert, but let's recollect another expert, Professor Mikhail Gergiadi, who changed the attitude toward decompensation because he established the register optimized HF, and he had 4 decompensations there, 4 fatal ones. Do you think SGLT2 inhibitors can change the situation? And I give the floor to Professor Mareev because he wanted to speak out. Yes. Well, if we take that fantastic picture with the compensations, yes, in average for the compensations, but some patients could be lucky and unlucky. For example, patient was hospitalized 8 times, unfortunately, but fortunately, patient is still alive. We know that SGLT2 inhibitors are fantastic drugs, and this is fantastic partner for quadruple treatment, and they would reduce the hospitalization and mortality risks. Then yes, this is something we should administer. Better to stable patient before the decompensation, but if it happens after, then let's do it after. Can we do it in hospital? Yes. If we take the EMPA, we have the study, we have the impulses, so we can start it, and this is just the issue of the label. For DAPA, we're expecting publication very soon, and I'm sure the result will be the same. But I would like to say a word about the clinical phenotyping. I totally agree that the clinical phenotyping is important, and I also totally agree that SGLT2 inhibitors are convenient drugs. They actually don't influence the pressure, no side effects, no potassium effect, etc., etc. But still, the studies with SGLT2 inhibitors, they included patients with pressure higher than 95. In case of hypertonia, it was not yet properly studied. I would be cautious. I would be cautious if patient has BP less than 90. But it would be interesting to get to other positions. Please comment on that. All right. Then I would like to give the floor to Professor Miloradovich. Could you comment the low pressure? And also, I would like to ask a question. You spoke that, in fact, in every patient with CHF, you can use DAPA. And it is clear that for every patient with CHF, we could see some degree of CKD. That's why we can use it. But are there any nuances to use SGLT2 inhibitors as a class and in DAPA in subpopulation of patients with CHF? CHF ischemic, CHF with hypertension, CHF with valvules, maybe with hypertrophic cardiomyopathy. So in these subpopulations, can we make any differences? What do you think? Please speak up.
When we looked in all of pre-specified subgroups in these studies, the effects of SGLT2 inhibitors was consistent. The more important that this study like DAPA and the liver trial not individually powered to test these effects. In pooled analysis, what I present, you can see that all results were statistically significant and very consistent through whole spectrum of action fraction. When we looked at the etiology, we don't see any statistically difference in the etiology when we're talking about effect of this group of medication. And what is more important, SGLT2 inhibitors could be initiated in patients with clinical diagnosis of heart failure while awaiting a measurement of action fraction. You know, for every patient, and what Professor Seferich just said, quickly in the first contact with this patient.
Ну, то есть различия между субпопуляциями...
So the difference between subpopulation does not exist, right?
Yes.
Отлично, спасибо большое.
Excellent. Thank you very much. Since you raised this question of phenotyping the patient, let's move on just not to heart failure, but also talk about chronic kidney disease, because also we must phenotype the patient in this case as well. In answer to this question and to start the discussion on chronic kidney disease, I'd like to give the floor to Irina. Irina, we know that dapagliflozin, which has been discussed today, has been studied and recommended for patients with nephropathy, and the 2021 guidelines allow us to use this drug for treating nephropathy. What is about the genesis of CKD? We're talking about nephropathy, diabetic nephropathy. Primarily, we are talking about different phenotypes, but can we talk about other genesis of CKD? Dear colleagues, of course, it's very important what kind of genesis of CKD, because when we're talking about the mode of action of SGLT2, we're talking about the general mechanism of action, about eliminating the hyperfiltration that occurs in the kidney. That's the general mechanism, but in case of different diseases, well, the origin can be different. And if it's originally the cardiovascular pathology, that means the hemodynamics has been in poor state, or there is a different situation when there are inflammatory diseases. And as for hyperfiltration. It can be caused also by diabetes mellitus. In this case, hyperfiltration is caused by neurohumoral dysfunction, and hyperfiltration is caused by diabetes mellitus per se. It's a different situation when we're talking about immunoinflammatory diseases. So in this case, we have the hyperfiltration in glomerulus when nephrons, some of the nephrons are lost, and we need to compensate this function. The nephrons are in a state of hyperfiltration. In this case, we can save the patient from this condition when some nephrons have already been lost. It doesn't matter whether it was inflammation or the kidney was lost as a result of reflux caused by the tumor, and so on and so forth. In this situation, well, the mechanism of action, well, must be taken into account. What led to this loss? If it was the immune disease, well, that's one thing. That means that there is a proteinuric effect, and of course, the therapy by using SGLT2 inhibitors, well, is one thing, and of course, in this case, well, the drug will be totally useless. But when we dealt with immune activity and controlled it, but when the patient is on maintenance therapy, in this case, well, we're talking about the hyperfiltration or proteinuria. We need to reduce the hyperfiltration. Of course, in this case, SGLT2 inhibitors should be administered. Well, and I should say that, well, this is the glomerulonephritis is the typical disease, which is very widespread. Also, glomerulonephritis patients are those who cause a lot of problems for us in terms of treatment. When we do not have the possibility of pathogenetic treatment, and of course, the nephroprotectors can be administered here. These are the patients who were included in the study, patients with proteinuria, patients with lack of immunosuppressive therapy, and that is why a large number of patients were included into the study, and we looked at the maintenance therapy when nephroprotection can be enhanced, and not because the drugs are special, but because the patients had these conditions. As for the fact that this is often the group of patients when maintenance therapy is administered, so these are patients with nephropathy primarily. I know that when the study assessed the primary renal pathology, patients with polycystic kidney disease were not included, and this disease is very widespread in the population, and there were concerns about cysts growth as well. The epithelium behaves differently as compared to the epithelium in normal, well, renal tubulars. In this case, the sodium will be accumulated in the cyst, and it can present a special problem. Well, also comorbid infections can be a problem, so these patients were excluded. Mostly, these were patients included in the study with the primary disease with minor proteinuria, although we saw that there were patients up to 5 grams. Well, if we look at DAPA CKD patients with proteinuria up to 5 grams, but not with this severe nephrotic syndrome, because hemodynamically unstable patients would not have such an effect. So to sum up, we can say, and that's my opinion, and maybe other sub-analysis and the accumulation of data will show the positive effect here, not only for nephropathy, but the patients with proteinuria who are on maintenance therapy, and we can enhance the effect of nephroprotection, not just the patients with nephropathy. We will have more data soon, and patients with membrane nephropathy, which is quite widespread in the adult population. But right now, there are sub-analyses which at least allow us to say that probably Such groups of drugs can be used as nephroprotectors in patients who do not have the cardiovascular pathology, but different primary renal diseases. And we can expand our capabilities of nephroprotection using this group of drugs in this group of patients. Thank you for this extended response. And before we go back to heart failure, I would like to touch upon CKD once again. Please be patient. That's a very important issue because we talked about this before. Nina had to go, but she mentioned the side effects, severe hypoglycemia. But let's look at the patient who has a hypoglycemia, who is on SGLT2 inhibitors. I'm not talking about insulinoma, but hypoglycemia because of the CKD of higher stages is quite possible. In this case, is it a risk or will it be benefit for a patient? Irina, I would like to ask you to comment on this, and maybe some other experts could join in later. Well, first of all, it should be said that CKD, when we're talking about advanced stages of CKD, of course, it increases the risk of hypoglycemia, and patients with diabetes mellitus are a shining example of it. If the patient has hypoglycemia as a result of, say, correction of glycemia, first and foremost, I would look not at CKD, but at the correction of the therapy, depending on the stage of renal insufficiency, and I would try not to cancel SGLT2 drugs, but probably to change the dose of such drugs. But at advanced CKD stage, patients with diabetes mellitus are treated with insulin, and there is a higher risk of hypoglycemia, but at the same time, we can correct the dose of the drug. So the risk depends on the type of hypoglycemia and what the patient gets when the patient has diabetes mellitus. If not just insulin, but also sugar-lowering drugs, such as the sulfonylurea drugs, for example, which are usually administered at the advanced stage, but not that many right now. Maybe we should look at the drugs when upon administration can have positive long-term effects. As for SGLT2 inhibitors, well, they do not have not just the sugar lowering effect, but we administer them because of the long-term effects, such as stopping the progression of renal insufficiency when there is a need of the highly expensive renal therapy. Well, I think we need a special session on chronic kidney disease. The more answers there are, the more questions we get. But let me just say that, of course, there is a question about antibiotics. Low GFR means there is a need to correct the dose of antibiotics, and aminopenicillins, 30 milliliter per minute is the low threshold, 10 milliliter for cephalosporins, and for fluoroquinolones such as levofloxacin, well, if it's 50 milliliters, then you should lower the dose by 4. Erythromycin below 40 is not allowed. Well, of course, you know that there are other roles of titration depending on the drug. Yes, the most important thing is the drug should be safe. Right. Now, a question is for our colleagues in Serbia. A question is provocative again. If we take a patient with the preserved ejection fraction and administer, because he has a CKD dapagliflozin, what improvements in terms of heart failure we can expect? Improving the quality of life, or maybe some other dynamics, or the reduction of the number of hospitalizations?
Professor Seferovich.
Yeah, so
Professor Seferovich.
It is a good question, but looking at the result of the trial, we already know. So the major thing here is that we are improving the lifespan of this patient, and we are also improving the possibility of being hospitalized for heart failure. So this is the major thing. However, if we look at the whole spectrum of heart failure, and this is extremely important, I show you the slide at the beginning of my presentation, that this is massive problem in Europe, very frequent disease with extremely high mortality. And the problem we had so far is that we did not have easy and straightforward way how to diagnose HFpEF. And this question is about HFpEF. Now, if we have the patient who came to the emergency room with shortness of breath, with elevated NT-proBNP or BNP in general, who has a left ventricular hypertrophy on EKG, this patient should be immediately given SGLT2 inhibitor. So the major stuff is that one therapeutic implication affect diagnostic implication, because we know that SGLT2 inhibitors are acting through the different stages of the cardiovascular, meaning heart failure spectrum. And we were able now to give SGLT2 inhibitors in all these circumstances. And this has a major and very vast clinical implication, because we were able now to diagnose any of the heart failure phenotypes and giving the drugs which are blocking the neurohumoral activation. But before these drugs, we already can give SGLT2 inhibitors, and this is a major problem. And what I like also to point it out was what Professor, let me see, Kafendra, so the professor who was discussing CKD said, so we now have the drug which acts on both kidney and heart. We know that this connection is extremely important. We know that the worsening of heart failure is mostly due to the worsening of the renal function. These drugs are affecting both the renal function and the heart function as well. So now we are able to say not only a renal aspect and heart failure aspect, but also diabetes, the patient with diabetes and patient without diabetes. So we are talking about the major revolution in our thinking how we treat heart failure. So we are not talking anymore, and this is also extremely important message, that we are not talking about the anti-diabetic drug anymore. We are talking about the drug which prolongs life, improves functional capacity, and prevents hospitalization. So this is a major difference than before, because we knew that SGLT2 inhibitors are beneficial, but we did not really understand how deep this benefit is going.
Огромное спасибо.
Thank you very much. And the next question, we have 10 minutes, and we have 3 types of questions. So I will ask all experts to answer this question. The first question concerns the ejection fraction. When we were talking about quadruple therapy, sartans, crucibitriol will lead to the increase of the ejection fraction in 3 months and 1 year up to 10%. Do we have similar data in figures? Well, for patients who are on dapagliflozin, can ejection fraction can be increased, or maybe other drugs related to SGLT2 class? That's not an easy question, by the way. The thing is that there are not so many studies here, well, which studied the function of the heart in detail using 2 SGLT inhibitors. Well, the results showed that, well, in some cases, the ejection fraction was not increased. Well, maybe they did not just follow the clinical dynamics. In some cases, there were some dynamics. There was an increase in the ejection fraction, well, by 3% only. Well, but the most important thing is whether we're going in the right direction, the right prognosis. If we look at different SGLT2 drugs, well, we can see that the ejection fraction increases slightly, but the prognosis is basically the same. Well, we cannot have grounds to say that in terms of different etiology, the effect will be different. So we must improve the prognosis. Well, as for the ejection fraction, it should not worry us a lot. If the ejection fraction increases, that's nice. If the patient wants to live longer, well, and the patient wants to have a reduced number of hospitalizations, which is nice. Thank you, Yuri. Some other expert opinions. Igor, please. Well, Yuri was absolutely correct. And today we understand that SGL2 inhibitors, well, can increase the ejection fraction by 3 to 5%, which is nice. Well, especially when we're talking about renin-angiotensin system, RAS. But we're talking about another situation. If we combine these two drugs, like RAS blockers and SGLT2, well, or ACE inhibitors, for example, we can add ACE inhibitors to beta blockers. Well, of course, in this case, we will have the maximum elevation of ejection fraction. Yes, ejection fraction elevation is nice. A priori, we mean this will improve the quality of life, but we are also talking about the other situation. There are other mechanisms that can improve the quality of life without increasing the ejection fraction, which is SGLT2 inhibitors, such as DAPA and empagliflozin. And of course, there haven't been studies concerning this particular aspect yet, but we can see this. Professor Miloradovich, please comment on this.
Звука нет. No sound.
Sorry, we have no sound.
We don't have hard evidence for this statement, and we know that elevation of ejection fraction is not main a reason for benefit of this group of medication. You know, some other mechanism who improve life and quality of life of our patient.
I will not worry about ejection fraction. So it is something which is different than in the past. So first of all, there are a lot of discussions about the importance and the value of ejection fraction in a different clinical setting. Don't think that SGLT2 inhibitors will improve ejection fraction tremendously, but think about the long-term benefit in survival and the decrease of the heart failure hospitalization. And that is probably the moment to once again underline that we don't exactly know what is the mechanism, which is probably complex, not only one, not only renal, but probably looking at what we have so far in cardiology, probably to some extent the hemodynamic mechanism. So we need to understand that the question of SGLT2 effect on the ejection fraction is a kind of redundant, because none of the drugs recently, including sacubitril valsartan, had such a profound effect on the long-term cardiovascular outcomes without any or with just small side effects which can be handled easily.
Professor Miloradovich, вы добавите?
Professor Miloradovich, would you like to add something? What's your take on that?
Yes, I agree with Professor Seferovich. we don't know any mechanism of this group of medication.
Yeah. Yeah, thank you.
Thank you. All right, so we can see that when we got down to main questions, the discussion is more heated. And of course, maybe some answers do not have enough proof, but we must focus not on treating the ejection fraction and not on the figures. We do not treat figures of the ejection fraction. We must focus on the result. And of course, in this case, the reduction in the number of hospitalizations, which is nice, and also the psychological, clinical improvement, of course, and in this case, the quality of life will improve, not according to questionnaires, but according to the self-assessment of the patient. They can also lead to the reduction of the dosage of different sulfonylurea drugs, etc. But as for CHF, there are arguable questions. As for CKD, the discussion will be even more heated. Well, we have two types of questions. Well, the first question is very simple. Well, as for glomerular filtration rate, we know 25 milliliters per minute. We know that if FR goes down, we continue the therapy, but the question is very simple. We say the earlier, the better you administer the drug, the better will be the situation. But if we're talking about hospitalization, let's say GFR 20, how can we know that at this moment it is 20? Because the patient has, for example, CHF, or now he has CKD. A week before it was 40 GFR. Well, the creatinine went up. We can use urea data, or kidney injury molecule test if it's possible. Well, maybe we can make a better diagnosis. What is the expert opinion on this score? Igor, please. Well, for Russia, the situation is peculiar. You mentioned different tests, and in the future, they will be used in Russia in clinical practice. But right now, when we're talking the situation now, when the patient has acute renal injury, well, GFR cannot be just 20, but can be 15 or even 10. And of course, in this case, SGLT inhibitors should not be administered. But if you manage the patient properly, GFR starts rising. And in this case, I, as a resuscitation specialist, understand that we can increase GFR. And in this case, dear colleagues, we must have a clear understanding that at this time, you should control the situation, treat the patient, reduce the probability of worsening kidney failure, kidney injury, and you analyze four situations: hemodynamics, inotropes, vasodilators, and also diuretics that can be administered per us. As soon as you have all this, you start administering SGLT2. In this case, you will improve the quality of life and you will reduce the number of hospitalizations. Well, I'd like to emphasize the key aspect mentioned by Igor. If at the stage of hospitalization, GFR is low, we cannot administer SGLT2 drug, but we must monitor this patient, and after some time, 3 months, we should reevaluate, reassess GFR, and maybe due to the baseline therapy, there was a positive dynamic. Well, in this case, the patient has GFR 30 or 40 milliliters per minute. That's very important. In this case, we can administer SGLT2. But if we lose the patient, if we do not monitor the patient, in this case, the patient may miss SGLT2. Otherwise, all the patients will drop out, and this, quadra or four-drug therapy will not be administered. Anyone else would like to say a few words about this threshold, 25 milliliters per minute? I would like to say a few things. Well, again, as for CKD, that's a nosologic disease, and there might be varied patients. It's one thing when the patient has proteinuria and has a progression of the disease. In this case, we can figure out when SGLT2 can be administered. We can monitor this patient, and the early SGLT2 therapy will allow us to prolong this treatment. And there is a different situation when we have a patient with a different phenotype, a patient who has a cardiovascular disease. And in this case, well, the patient cannot get out of the situation. There might be progression of CKD at the same time. Of course, we should look at the dynamic first and also our approaches in assessment, because we all know that, and you've mentioned this before, creatinine as a marker cannot be sometimes a good marker of GFR, and we can have problems with the level of creatinine as well, and it can harm in terms of administration or non-administration of a particular drug. And this relates not only to SGLT2 inhibitors, but to other drugs. As for patients with acute kidney injury, well, this formula do not work at all, but we will just look at the creatinine or cystatin level and their concentrations. But what is important is that this should not be the starting point not to administer. This should be the starting point in today's condition, depending on the dynamic situation. It's the same situation when the nephrologist sees first the patient, and the patient doesn't know his history, and we look at the creatinine level. What is it? The old CKD, or maybe there is another acute situation. We should examine the patient first, the size of the kidney, other markers, well, manifesting CKD. So we should look at the specific situation. We should look at the fact whether that's a temporary condition, maybe the wrong dose of the drugs the patient has, or maybe there is some other condition. We must stabilize the patient, and then we can say this GFR, was it just the temporary condition we decided to avoid SGLT2 inhibitors for the time being, or maybe this is not a temporary situation, but maybe this is the reduction of GFR due to the specific stage of CKD. I agree with you. We must monitor such patients who had several episodes like this, like CKD. And at the same time, we should not deprive this patient of getting the necessary SGLT drug in the future, because this will have an impact on survival. And we're calculating not the hemodynamic effect. We believe that the mortality will be reduced if patients get SGLT2 inhibitors. And the patients who have renal insufficiency, they will die from cardiovascular disease if they do not get the SGLT2 inhibitors. So SGLT2 inhibitors have an impact on not just mobility, but also on mortality. And this group of drugs showed very nice results. Professor Sefirovich has already mentioned this. Well, SGLT2 inhibitors, well, at the molecular level, can have different mechanisms of action, reducing apoptosis, for example, reducing the mitochondrial dysfunction, and it's not just a hemodynamic effect. So there are long-term consequences from the administration of SGLT2. Another thing is that it's advanced CKD patients should be on dialysis or almost on dialysis. Well, a lot of nephrons have been lost, tubulars are not properly functioning. How can SGLT2 inhibitor will be acting on? And of course, we can see that In this case, it can be active on myocardial cells. The patient can be on dialysis. Well, the heart will be working, but the question is to what extent that's a contraindication to using SGLT2 at the advanced CKD stage. Thank you for this answer. Let me just remark that the formula for calculating GFR has changed. RAS is not taken into account anymore. Cystatin C is taken into account. And here is our final question, because we're behind time. And again, please express your opinions. We started by saying that now, wow, we have new cases of CHF because of COVID-19, and not just because of COVID-19. It's because of the chronic diseases which were not treated due to the lockdown, or it can be caused by COVID-19. The patient had myocarditis or aggressive therapy with glucocorticosteroids. And also the same is true of CKD. The patient had acute kidney injury. Many patients who had such symptoms at home and had COVID-19 had something like that. So we can see that this pool of patients is much younger. How can we convince these younger patients, much younger patients, I should say, how can we convince them that they need treatment of SGLT2? Well, maybe we need something like visual scales, like for therapy with statins, so when we can look at the dynamic of his life and the reduction of life expectancy. Maybe there are some other considerations as far as younger patients are concerned. These people go in for sports because they're young, they do sports. And of course, due to CKD, they can encounter the loss of protein because of the high pressure while doing sports. But anyway, these young people, well, in conclusion of this session, what is your position? How can you motivate these people for treatment? Because these are new patients. They never encountered this diagnosis before. Well, I would not demonize COVID-19. COVID-19, hopefully did not have such a great effect, but we can see that there are other conditions which had a much worse effect on our patients. So do not demonize COVID-19. Well, first of all, in order to avoid problems with CHF and CKD, let's start treatment properly at the initial stage. Let's measure the blood pressure, administer statins, and in this case, we have a less number of patients like this. It's quite obvious, and if the patient at 60 or at 50 gets statins properly, in this case, CHF will be less detrimental in several years. Well, it's nice if we can say that the dynamic is positive. Well, I personally have my experience. Of course, it's not the ideal one, but I don't know sometimes how to convince a young patient to take drugs. Maybe I can give such patients the results of the randomized trials, but it's not quite possible sometimes because, the trials can be inconclusive. I disagree with you concerning not demonizing COVID-19, and we can see that COVID-19 can lead to an increased number of complications such as hypertension. We had 4 times more of diabetes mellitus and coronary heart disease increased by a factor of 7 among those who had COVID-19. So we have more cases of CKD and CHF due to COVID-19. Igor, well, your final words, because I was told that we must wrap this up. Well, on average, we can see that there will be an increase of chronic heart failure by 30% in the next 5 to 7 years. As for young patients, we must use different psychological tricks to discuss, first of all, the patient's problems together. We can say that we can solve your problems through concerted efforts. And of course, the young patient will be ready to cooperate. So counseling is important here. And so we should use the bottom-up approach, not the top-down approach. I am absolutely sure that young people are more pragmatic. And that is why if I act as a partner, they will follow my recommendations. Thank you very much, Professor Seferovic.
I think that in the session like this one, we need to transfer big messages. So we should not speak about the scientific details, because you have 1,300 people around, and the messages they should think about and that they should memorize are the following. First, SGLT2 inhibitors are not diabetic drug. These are cardiovascular drug with excellent effect on heart failure hospitalization and cardiovascular death. This is the first thing they need to understand. Those drugs are acting through the whole spectrum of heart failure continuum, heart failure spectrum, from HFpEF to HFrEF to the acute worsening heart failure. No drugs were proved to act the same way. These drugs are simple to use, easy to administer. There is one dosage, there is no up-titration, and the side effects are very small. And as most important, last but not least, is that these drugs should be the first which should be given to the patient in phenotyping the other heart failure drug. Because we now have new strategies and new drugs in heart failure, and we need to prioritize the speed of giving different drugs in terms of up-titration. So these are the most important facts which we need to understand. Also having in mind that probably the best is yet to come, because we don't know what the future holds for SGLT2 inhibitors, but we hope that that will be something really good.
Спасибо большое.
Thank you very much. I was told that we are over in our time. Irina, just the final words, and then Professor Miloradovic. Irina, please, first. Well, I'd like to go back to the question in talking about the young people. I'd like to go back to monitoring patients, dispensary monitoring of patients, medical checkups of patients, because not all patients have severe complications. Well, usually these are patients in the risk group, and in fact, these patients should be monitored. They should not drop out. When they came to see a therapist, we must identify what kind of risk well, the therapist should pay attention to with such patients when we show our combined risk scale of cardiovascular diseases and renal diseases, when the patient may have serious problems and they might be galloping renal insufficiency. Well, usually young patients are very impressed when you show such scales, and they ask the doctor, what should I take to avoid this? And of course, well, here everything depends on the ability of the therapist, on the ability of the doctor to explain everything clearly to the patient without confusing him. Well, an ounce of prevention is worth a pound of cure. And in this case, the patient will listen to the therapist. We as cardiologists and nephrologists have a lot of instruments, a lot of drugs. The most important thing is how to present these drugs, these methods to our patients. And right now, we have all the necessary instruments allowing us to do it at the early stage and avoiding those advanced stages when the patient has a very high risk of death from CKD or cardiovascular complications. So the most important thing is to communicate this message to the patient. Professor Miloradovic, your final words.
Yes. What is more important for young people? It's few facts. This medication is simple to use. These medications are hemodynamic neutral. And what is more important, all data said that the adverse event of this group of medication is like placebo. It's more important. Simply to use, neutral hemodynamically, and adverse event is not noticed.
Спасибо.
Thank you very much for your brevity, dear experts, dear listeners. I would like to thank you for participating in this speed session. We raised a lot of questions. We provided answers to most questions, not to all. I realize that we're pressed in time, and we will keep sending you some of the questions to get answers. We have a lot of specialized questions that came, but we have no time to answer them. We will publish your answers in our Telegram chat. So, dear experts, we are talking about CHF and CKD together. This is the trend that we will follow in the future. Thank you very much, dear experts. Thank you very much. We will have a break and we will reconvene in 44 minutes. Thank you.
Bye-bye. Have a nice time. And thank you for having us here. Bye-bye.
Thank you.
Yeah. Thank you very much. Спасибо большое. Всем спасибо. До свидания.